Implants are a well-established part of our practice nowadays and very predictable in terms of long-term success. One thing that patients sometimes don't realise though is that we're not usually placing an implant where there has previously been a healthy tooth. So often there's been chronic infection that's gone on for many years and has usually damaged the bone in the site where we want to place the implant. In terms of how we classify the complexity of the implants that we're going to place for patients, there are three: straightforward, which is simply drill a hole, put an implant into it because there's plenty of bone. Or we then move into the advanced, where we have to place the implant into damaged bone and then graft the bone around it using biomaterials I'll talk about in just a sec. Or the complicated or complex, where we have to actually manipulate the tissues to create new bone where there wasn't any, into which we can then place implants later. And they're where the most enjoyable cases are, because we're able to put teeth where previously it would have been impossible. The biomaterials we use are based, certainly in the system that I use, are based on cow bone and pig membranes. And we have to be very careful about the consent process, because obviously some people have sensitivities about the use of animal-derived biomaterials, but they are very predictably successful. And certainly Geistlich, which is the company who produce the products that I use, have been around for 25, 30 years. Very, very good long-term studies into the success of these materials. I would say on average that I probably graft in about 80-85% of the cases that I place, purely and simply to make sure there's plenty of bone around the implant to protect it so that it has the maximum possible life expectancy. And from a patient's point of view, it's quite interesting to watch the process as they realise that we're actually going to use specially prepared biomaterials in a very careful way to produce a nice big block of bone to put the implants into. It takes them a little while to get their head around that, but actually as the process goes through and they can see the bone developing and more importantly feel the solid block of bone that we put the implant into, it gives them a lot more confidence. We always have to assess the treatment before we start. We don't just wing it and see what happens as we go along. We have very well established treatment protocols which are evidence-based routines that we know will work. And so, for example, if I place a small graft at the same time as an implant, as long as the implant primary stability is good, which we can measure using a little magnetic device, then we can have full confidence that we can actually start to rehabilitate and rebuild that crown, even if the graft hasn't fully taken. That's just going to be an augmentation just to give it more strength in the long term. If we're placing a large graft into an area where there's been a large defect within the bone, then obviously we have to leave that a little bit longer because the bone has to travel further into the graft to become solid. We have one case on at the moment, which is a very novel technique, where there's a very large defect and we can't just use particulate graft alone. We have to use a titanium mesh, which is CAD-CAM built from a CBC. Basically, it's a cone beam CT scan is taken, which gives us a 3D image of the defect. That then goes off as an email attachment to Germany, and they construct a metallic lattice that's screwed onto the surface where the defect is and holds the cow bone into the defect area, which means we have a very, very stable graft. And in this particular case, it's a large 3-to-3, it's a 6-unit defect, which will rebuild the tissues that never actually grew because this lady lost these teeth when she was 15. And so we rebuild a block of new bone. She has a new premaxilla into which we can then put whichever implants we want and rebuild it and get a much better cosmetic and functional outcome.